welcome. Thanks for taking time over your lunch hour to join us today. And I wanted to thank AHA as well for helping us set this up and inviting people to come join. My name is Kendra Sticka. I'm the Executive Director for HealthEconnect Alaska, Alaska's Health Information Exchange. And I want to introduce the two team members I have with me today from HealthEconnect. Mary Eckert is our clinical engagement specialist and is going to be presenting with me today, really to do a demonstration of the portal and walk through that element of it. And Carlin Ivanoff is our director of clinical informatics. Carlin is going to be here monitoring the chat. So if you have anything in chat, she'll be monitoring that as well as helping with questions as we kind of walk through this presentation. So HealthEconnect Alaska, I'm going to start with a little bit of who we are for those of you who are new or haven't been engaged with the Health Information Exchange for a while. HealthEconnect has gone through some big changes in the past couple of years, so we'll give just a little bit of a background on that and then really dedicate the bulk of our time to a demonstration of the portal and some of the services that are available to you. And then we will shift gears a little bit to talk a little bit about some of the maybe less traditional ways the Health Information Exchange can be used, and also hopefully have a little bit of dialogue with you all in terms of maybe some of the opportunities for the Health Information Exchange going forward. So first of all, our story. And Mary, I might have to have you click through slides if you don't mind. So our story, just HealthEconnect, for those of you who don't know, is a nonprofit organization. So we are really here to facilitate comprehensive health data sharing and utility tools, really to improve the health of Alaskans. And as we talk about what we do and our goals and what kinds of things we're working on, really that ultimate customer, so to speak, for us is Alaskans and the patients that we serve. And then, of course, all of you play a role in actually providing the care. So HealthEconnect was established as a result of legislation when there was legislation to stand up an HIE, and HealthEconnect was that organization. So our goal is to improve the safety, cost effectiveness, and quality of care in Alaska. On the next slide, just really kind of showing that we are a public good for Alaskans. Oops. And in saying this, it really does mean that we are here to be part of the healthcare community and think about how we can work together to use data to make better care decisions, more efficient and more effective care. At this time, the state has been very good with supporting HealthEconnect Alaska and the HIE to be a tool so that we can offer pretty much most of the things we're showing today can be offered without a cost to individual organizations because the state has supported that. So it really is a public good for all of us to be able to utilize. On the next slide, we have a bit of a picture of a little bit about our technology infrastructure. Again, this is if some of you have been involved with the HIE a while back and haven't been for the last couple of years. HealthEconnect did a fairly significant shift 2 years ago, and we became an affiliate member of CRISP Shared Services. CRISP Maryland was Maryland's Health Information Exchange and found that they had a very effective model of an HIE and decided to stand up a shared services model so that other states could come together and really leverage the economies of scale for pooled innovation and technology. So we became an affiliate member of CRISP Shared Services 2 years ago. So that really means that we share the technology platform with them, but also in addition to that, it's shared governance and it's really sort of shared innovation. So coming together with other health information exchange leaders and looking at how we move forward with what the current needs are, as we know those change really quickly. So we're happy to be a member of CRISP Shared Services, and we feel like that's serving Alaska very well. The next slide has just a little bit, I won't go into a lot of detail about our technology architecture because we want really more, the use that people see, but sort of on the back end, I think it's worth just recognizing how the technology infrastructure works. So at the center of this diagram is the master person index or master patient index. And I think that's a critical piece of understanding as people are learning about the HIE, that the HIE is not a repository of data that's just open for anybody to come look at any, health information that's in there. we are regulated by the same and actually sometimes stricter regulations than every healthcare organization is, HIPAA and all the related elements of that. So essentially, there's a variety of ways that information can come into the Health Information Exchange data repository. So on the left side of the screen, there are some of those ways. Alaska uses some of these and doesn't use some of these yet, but within our technology infrastructure, these are all options of ways data can come into our data repository. And then essentially that's matched up against a consent utility tool that ensures that the proper consents, as well as the proper allowances based on the known patient relationships, are taken into account before that information is ever delivered out to someone or someone can access it. So today, Mary's going to do a demonstration of the HIE portal, the HealthEconnect portal, and that's one way that people can access information from the Health Information Exchange. But depending on the use, we also sometimes provide people flat files of information. We have an event notification system that Mary will talk about that's in the portal as well. So there's a variety of ways that that information can be delivered. So just to kind of give you an awareness as you're going through this and learning a bit more and thinking about how it might be useful to you, knowing that there's not just a one-size-fits-all approach. So with that little bit of intro, I will turn it over to Mary, and she is going to do a demonstration of the portal. She'll walk through and we can have time for questions at the end, but we're a small enough group that I would say, please feel free to just pop a hand up or pop a question in the chat if you have it as we go and you feel like it would be more helpful to stop along the way. We certainly can do that as well.
Yes, thanks, Kendra. And hi, everyone. My name's Mary. I've been with HealthEconnect for just over a year. I'm based out in the Mat-Su Valley. When I'm not working on HealthEconnect projects, I am a practicing physician assistant. So I'm excited that I get to show you about the clinical application of the tool and how we use this on a day-to-day basis. So I hope everyone can see I'm sharing my screen, and this is just our website. If you healtheconnectak.org, this is our homepage, and you would just, if you have access, if your organization has access, you would just go to the portal login. It's a web-based portal, with the exception of a few EMRs that support single sign-on. So if your organization is a participant and uses Athena, eClinicalWorks, Allscripts, to name a few of them, I think Allscripts is now Veradigm, those offer single sign-on where you can just actually navigate to this information within the patient's file. For everyone else, you're going to be accessing through the login. And I have already logged in because it is a two-factor authentication process. You know, we're HIPAA compliant, so you have to have a cell phone linked. So I went ahead and logged in to save you watching that step. But once you get to this landing page, I feel like it's very familiar looking to anyone who has used an EMR or an EHR. We will go ahead and search up our first test patient. At minimum, you have to have a first name, last name, and date of birth. And we've got lots of Gilbert grapes. If you've got multiple patients with similar dates of birth, similar name spellings, this match score might help you choose. A yellow match score over 100 is usually a pretty safe bet. I happen to know this is the Gilbert grape I'm looking for. And this clinical information is where you'll find yourself going probably 99% of the time. Kind of the bulk of the record there. Oops, I have to choose him again. Now we are actually in Mr. Gilbert Grape's chart. So over here on the left, we've got some navigation buttons and then some columns across the top. This patient information is helpful if you're looking for updated demographics, perhaps updated contact information or next of kin. But all those medical records are going to be here under the clinical data, and specifically the health records that I've got highlighted right now. This can all be sorted by laboratory, lab records, radiology, so imaging reports, clinical notes. This would be transcriptions from hospitals or clinics. These can all be sorted by date. You can even search for Providence, for example, if you're trying to narrow it down, if your patient's been seen a lot. Across the top here, this would be if there's active problem list diagnosis codes entered in the patient's chart. You can kind of get an overview snapshot here. Structured documents I want to mention because, well, for a couple of reasons. So these are where CCDAs, that's Consolidated Clinical Document Architecture, for those that care. It's a standardized format essentially for sharing medical records. In some hospitals and clinics, this is all they can send. And so this is where those CCDAs would specifically land. And this is where our national network, so if there's anything coming in from hospitals out of state where your patient's been, this is where you would find that information as well. This is a test database, test patient, so it's slower than the real thing. Hoping that would pull up the national so I could show you that list. So here, for example, is all of the out-of-state partners that have sent CCDAs on Gilbert. And then lastly, over here, immunizations, if there's any immunization data available, that's where it would show up. But I thought we would dive in specifically to the health records just a little deeper for a moment. I'll just choose a lab. So now we're in what I would call the lab bucket, all the labs. And you can click on any one of these and it will pull up the lab in detail. And it can be downloaded as a PDF and printed, downloaded and incorporated into the local chart. Back to the clinical data because I skipped over this encounters tab. This is a list of just where your patient's been. If there's a lot of information in that health records tab, that can be overwhelming and you're just needing to see a quick list of inpatient versus outpatient visits, you're going to find it here under the encounter tab, and that can be sorted again by everything or just hospital, just outpatient visits. For those with the more technical background, this is going to be populated by those ADT messages, which is short for admit, discharge, and transfer. Any questions, please feel free. If there's anything you want to see in more detail. I wanted to show you also that we can see a medication list. Oh, Gilbert doesn't have any active medications. Well, if there were any active medications based on what we'd received in CCDAs, these would be parsed here. And you can quickly pull up a medication list. And the other thing I like, it gets me excited as a clinician, is this PMP button takes you directly to the Alaska Prescription Drug Monitoring Program. And querying here does count as a loggable or auditable instance, so it saves the provider or clinician from having to go to yet another external website. So far, everything that I've been showing you is specific to our one patient. And I've got one other thing I wanted to show you. It'll let me. It kicked me out. Well, I'll come back to that. Like it kicked me out and I'm gonna have to log back in. Sorry, guys.
Well, Mary's logging back in on that. There's a couple of questions in the chat that I think we can touch on.
Perfect.
In terms of, yeah, you can log back in, Mary. In terms of consenting, so Alaska is an opt-out state, so patients are automatically in the HIE unless they explicitly opt out, with the exception of SUD and mental health data. For that, they do have to specifically opt in and consent for that. So for example, if it was a high utilizer program, patients would be in the portal and could be used for that. Again, it's all based on known patients for an entity, but but that's the opt-in, opt-out situation. And then Matt, your question in terms of whether there's any kind of API available to interact with HIE programmatically, and I'm not the techie person, so anybody else on my team, feel free to jump in, but I think in terms of that, like a single sign-on within an EMR, that is available for some. And so, yes, so Carlin's my, I'm more techie, but yes, not for everyone, but we do certainly have single sign-on, and we know when single sign-on is enabled, that makes it much easier in terms of the workflow. So there are options for that with a range of EMRs or other platforms as well. Not necessarily just EMRs. We looked at APIs with other things as well. So we can definitely talk about if anyone has a specific application we're looking at, we can talk individually and schedule some time to see what that might look like, or if that particular tool has been integrated in the past. Not that it can't be if it hasn't, but that would be the process for that.
All right, I am logged back in, and the consent question was perfect because that was actually the last thing I wanted to show you about Mr. Gilbert Grape here. This consent tool, specifically for those sensitive records, substance use disorder, mental health treatment information, there is a way to consent the patient or client right at the bedside. And so far, everything that we've looked at is essentially, I think of it as being read-only, meaning that no corrections, changes, entries, or orders can be made. The consent form would be the only time that you would actually be entering something into the HIE directly. And this would be if a patient who is receiving these services wished to share or wished to not share. You can fill this out right there at the bedside. You know, it's yes, no, it's good for up to 5 years. They can choose an expiration date for a year, next year, whatever they like, and they just would sign at the bottom, and you would just enter the name of the clinician or whoever helped them fill this out. So that's kind of handy. Then I'm going to jump out of Gilbert's chart. Everything we've been doing so far has been very specific to just our one patient or client. This tool is our care coordination tool or care management tool. So this looks at a whole patient population, the entire panel of patients that belongs to a particular agency or organization. Currently, it goes by the name ENS prompt, that stands for Encounter Notification System. And it's essentially a tool to sort through your entire panel and see what has happened. You can run this list daily, weekly, monthly. It can be configured in any number of ways. There's custom filters that can be put in place. We could search by just ER visits or just hospital visits, ER visits, admit and discharge. You can work through this list online. This is test data, of course, is why these patients have funny names. You can work through them online. That's what the status button is here, started, not started, in progress, but most folks choose to just export a list. You can download a CSV file right from here as often as you need to. This is not new technology. There are entire accountable care organizations, big ACOs in the lower 48 that are building their entire business around this model of being able to sort through patient panels. So with that, unless there is anything specific you'd like me to show within the platform, I will hop back to the remainder of our slideshow. And there are screenshots that'll be included for everyone of those basic features within the HIE, and we'll send that out afterwards. But there we are. We should be on our list of current participants now. This list is ever changing, but it shows what kind of information we get from the various participants who are currently contributing data to the Health Information Exchange. As you can see, it's definitely not a one size fits all. At minimum, we've got some agencies sending us just ADT, so just those lists that say, yes, patient was here. Some clinics and hospitals are able to send us virtually everything, labs, imaging, full clinic notes. And here we've got a list of hospitals and what the hospitals are currently sending us. Just like the clinics, it really varies from one to the next. All right, and I will hand it back over to Kendra to just kind of wrap things up, unless there's specific questions about any of that so far.
Sounds good. Thanks, Mary. And I'll pause. I mean, anybody, or feel free to, again, interrupt, jump in if it's helpful to pop back. So just a few slides here in terms of services. Again, what Mary just demonstrated, the portal is really that key element or that key tool for point of care. And I think that's historically really a lot of how HIEs have been used, is looking at health information across different systems that maybe don't talk to each other otherwise. So that can be a particularly valuable tool for that point of care. I think what continues to probably evolve and grow is the care coordination aspect and the public health data utility and health data utility in general. So I'll talk a little bit more about those. Care coordination, and Mary demonstrated too that filter option. And just to emphasize, within that portal, there are innumerable number of filters depending on your role and your setting, what would be most applicable to really use that tool to run those filters, so that as you're looking across your population of patients and how to really help a whole population or coordinate care for those individuals, that you can use those filters. So there are lots of options, and that's also an area that, as we look at growth in the CRISP Shared Services group, I think there's lots of emphasis on expanding and enhancing those types of tools. So if that's something that's of interest and you would like more detail on that, we can certainly dive in, again, specific to your unique situation. A public health data utility, and again, a health data utility, I have another slide on it that I'll touch on that a little bit more. But really the idea that collecting and connecting these various sources of health data that come in and delivering it in a much more concise format, so it's not pulling data from so many different types of places. So for example, in public health, in registries, like the birth defects registry, for example, if someone's investigating that, they would have to go to all sorts of different sources to gather information on that individual. Now, the HIE doesn't have everything that's needed, but it's a great starting place to get a big chunk of what's needed and then fill in the gaps, rather than just doing individual sources for all of those. So really that element of a public health data utility, I think, is growing, and really looking at how the HIE can be used for Alaska to make that smoother and more efficient. Managing the cost of care is really about the right care at the right time to support those efficiencies. And I think sometimes it's easy when we talk about efficiencies that it feels like, oh, that's getting by on the cheap. And I think we recognize that's not just the case. Certainly we want cost to be controlled for patients, but it's often also about the right type of care for the situation. So really managing that cost, and also with that, I think, is managing the appropriate type of care for whatever that patient needs at that given time. Then if we want to hop to the next slide, Mary, we just have a few numbers here. And again, nothing this changes all the time, but I think really to acknowledge that there are a lot of organizations that are contributing data to the HIE that we get either directly from them or through national networks. This is an area that we continue to work on. How do we grow that data repository so that it's more and more useful to people? The organizations subscribing to event notification services, this is also an area that I think we'd like to help people think about how that might be a useful tool for them, because it is something that can really customize and filter through the data. I think we all are probably in a place in our whole worlds, not just this, that there's more information than you can do, than you can reasonably use in a day sometimes. And so how do we organize that in a way that it makes it very actionable for you? So that's an area we'd really like to support. Again, just some numbers on the HealthEconnect portal users, people who are subscribed, and then alerts that are being sent to providers about their patients. One thing I will also emphasize about the alerts being sent to providers, that is provider driven and selected. So I think it can start to feel like the last thing I want is any more alerts popping up on my screen. So this is really driven by the provider and what's useful to them, not that it's an automatic alert to give them something that they don't want. On the next slide, we have just a reminder about approved uses of the HIE. So just to reiterate, our guiding documents, laws, are not just HIPAA, but there's also legislation that dictates how information in the HIE can be used. So it is explicitly for care coordination, treatment, billing, and then approved public health uses. And so that public health use is also things that are, for example, reportable conditions. So it's really about providing back to the Department of Health information that they have access to or have the right to have anyway. It's just in a cleaner, easier to get format, and helping healthcare organizations who are required to report that information get it through in a streamlined process to the extent possible. And I think this slide is really important because as people start to think about where do they want to put their data in and how do they want to pull data out, it is important to recognize that this is very protected and it's very prescriptive in terms of how it can be used, so that keeps patients' data safe. The next slide, again, a little bit more on health data utility. And I guess I worked this in a few different places because I think this is really where there's opportunities for us to think as a state and as individual organizations. What are ways that the Health Information Exchange as a state designated HIE and really a utility, much as we think about power or other things, that there's the infrastructure in place? How do we use that infrastructure really to benefit the care that you provide to patients and clients? So the idea of health data utility, some of you may be familiar with that, some of you may not. I think it's really, it's to some extent probably an evolution of HIEs in a lot of ways, in that there's many ways now that information is just strictly transmitted in its raw form from place to place. That used to be novel. Now that's just standard operations, and there's lots of places you can get information. But again, the downside of that is really that sometimes there's too much information to really be able to make it actionable and to filter through. So I think the idea really with health data utilities is how do you collect all this disparate sources of data in a secure repository, make sure it stays protected in terms of privacy, consent, those types of issues. How do you connect that data into ways that make it actually actionable, filter out the things that are irrelevant for a particular situation, make sure there's the things that are relevant, and then deliver it back to a person who actually has the ability to take action on that data. So one example I would highlight here, we are working on a pilot project at the moment on social determinants of health or social drivers of health. So most of you are probably very familiar with those and familiar with sort of the increased emphasis and requirements around assessing those and reporting those. So we're using the Z codes that are coded primarily coming in from hospitals at this point in time into the data repository. Taking those Z code data, that Z code data, and matching it up against a patient panel for Matsu Health Services, who has agreed to work with us on this pilot, which is fantastic. So we're matching it against their panel and then providing them back a list of patients on their panel who have been identified as having some type of social health need through a Z code. And then that way they have one more tool in their toolbox to outreach to those patients and see how they might be able to support them, connect them with available resources, get them in much more quickly. So those are the types of things that we're really working to grow and develop in terms of how do we get information that lives somewhere into the hands of someone who can actually take action on that.
As I go to the next slide here, I'll just point out a question in the chat that Brienne asked that was a really good question about how burdensome it is to input data. And Carlin did answer in the chat there, but essentially the onboarding process when an agency is decided to participate is helping build that integration. And so it is automatic is the answer. There's no dual entry. No clinics have to also put their data into the HIE. It happens behind the scenes. That's our job. And I'll go ahead and advance here.
Thanks, Mary. Yeah, that's a super important point, and I'm glad you pulled that up. Because I know nobody has time for entering into two systems. So yeah, all behind the scenes once that integration takes place, which is really the whole intent of the HIE, is that it integrates the systems behind the scenes. I was in a meeting last week with OMB talking about funding, and we were talking about how when the HIE is working at its best, it's sort of invisible to everybody on the front, which makes it kind of hopefully less exciting, because it's very invisible. It all sort of happens behind the scenes once those integrations are set up. So on the screen is just a few sample use cases, and these obviously aren't going to be specific examples that apply to everybody here, but I wanted to put them up more just as you start to think about, what way might the HIE be useful to my organization or me in my work that I hadn't thought about otherwise. So these are just a few examples. For example, Medicaid looking at top reasons for non-emergent ED utilization. We know when people are using the ED for non-emergent reasons, it's not only expensive, but again, it's not giving them the care that's most appropriate for what they need at that point of time. So having some more visibility into that, so that then their primary care home or whoever is appropriate can reach out to that patient and see how they can support them. Perhaps an FQHC care manager, again, looking at ED utilization patterns with a particular diagnosis. So these are all things that through different filters and setting those up, that you can look at very specific elements or a mixture of specific elements about your patient population to see how you can best support them, what types of services you might need to offer in a different way, what might be a topic for, a group class or a series, or, just depending on the situation. So these are just a few sample use cases. And then I think the second to the last slide we have here, and I'll kind of stop talking here for a minute. I think really, as I mentioned at the beginning, we are set up through, just cut the chat one to make sure we hit that. We're a nonprofit. We are here to support the Alaskan healthcare system and be a part of that. And so I think our team was really interested to just throw out a few questions or others to hear from you all for a little bit, and certainly you could follow up with us afterwards. But where do you have data gaps that impede your ability to function in a way you'd like to? Kind of that, if I only knew this. And is the HIE potentially a solution for that? It may or may not be, but it's helpful for us to have a sense of where you're feeling the rub and could use that. And then in what way do those data gaps relate to that point of care need, and what are more the care coordination needs? Both very important, but helping us see where the bigger gaps are is helpful as we think about moving forward as well. Something we've also talked a lot about is health equity and the role of health data in closing equity gaps. And so I think this is probably something most organizations are having conversations about, health equity. So wondering if there's thoughts about types of data that would help you make decisions in your practices or your care to close those equity gaps or narrow those equity gaps, how data might help with that. So I am going to pause there. And there's one question in the chat too. We can comment on that. Carlin's writing on that, but I'm going to be quiet and just see if people have thoughts on any of these questions here or other things that you feel like might be of value for the HIE or might be helpful for us to have on the radar as we think about where we put priorities and efforts.
One of the things that I'm a Dr. Oswald, I work with the complex care unit in the Department of Family and Community Services. And I think an area that this would really be helpful is for those with serious and persistent mental illness and those with complex cases that maybe bounce between different ERs, primary care, Department of Corrections, API, and there's a lot of data that gets lost of maybe a behavior plan or a crisis intervention plan or even what medications they're on. Would be helpful information. And I could see that being like an alert that, hey, somebody's leaving from API, but they're going to Utiavik. Like, how can we wrap in the ER there with their behavior plan or what they might see presentation wise, or even their picture? Because we have like ex partes that we track data with, and that might be a piece of information where we have somebody. Sorry, I'm in hospital right now, and so there's a lot of background noise, but just tracking information that they might be in Anchorage and then all of a sudden they're in Kenai and now they're popping up in the Mat-Su area, and how do we, have consistent care across those areas? So that's something that I think about when I hear about this presentation.
Yeah, thank you for bringing all of that up. I think that's a perfect application of where, at minimum, you can see those encounter lists and at least put a timeline together. We don't get full clinic notes from all of those places you just mentioned, but API, for example, we can at least date and time, what days they were there, when they went in, when they went out, or where to start trying to track down records. And then those active medication lists we get from quite a few organizations. And Carlin might be able to shed a little bit more light on that. I think the biggest issue with the sensitive data is a lot of patients don't want to share. So a lot of that behavioral health stuff is hidden behind a break the glass repository. Yeah, there's our answer from Carlin. You have to have consented to share that data.
Yeah, and I think just to add one more thing on there, we were talking with our clinical director, Dr. Becker here, and one of the things too are I'm forgetting the terminology, but essentially what happens is like when a patient is stable and agreeable that they provide consent ahead of time for sharing like medications and different things. And obviously if they want to, great. If not, there's nothing you can do at that point. But that would be also helpful information for people, or at least passing along, like we have a lot of patients with contraindications for medications, not necessarily that that's an allergy, but we know that it just does not work for them. And I think that information would be well. So if there was this consent and if it's wrapped in there, like how can we communicate that with the ER? I think Dr. Zink said it really well. How can we not undo the good work that's done ahead of time by giving them the thing that normally works, but maybe doesn't work for this patient?
I think that's a great point, and definitely some conversations we've had, and there's, I think, a lot of interest related to behavioral health. And I think there are also some things about how do we, and again, we as providers, as a state, as people working with individuals with those behavioral health and mental health needs, how do we think about helping protect their privacy without making it be a disservice to them, right? So thinking about how do we structure that and how do we talk to patients about consent that help give the information to the right people, because obviously that's not helpful for them if someone doesn't know a particular medication that just doesn't work for them. So I think there's a lot of nuances that is going to be important that we think about. How do we strike that balance between making sure patients do absolutely retain control of their data in the way they want, but also helping them think through what the implications of that are and where it might be beneficial to share.
Yeah, I loved your point about talking with patients when it's not in crisis mode ahead of time. I know there's never enough time in the day, but being able to do that consent at the bedside, I think from someone that they trust, that can explain that this could be life-saving in the future. And the conversations I have with patients, I don't work in behavioral health, but more the primary care side, it's like I remind them this is just like an electronic medical record, in the sense that your neighbor's not looking you up. Your school can't look you up. I mean, only healthcare providers can see your information, and anyone who accesses your chart has to attest why they're in there. So if that helps that conversation at all with patients.
Thanks, Mary. And so just to kind of wrap up, I know we're almost at time here and I want to be respectful of everyone's time. As you're kind of thinking about through this presentation, we decided to just sort of do a very broad, wide swath of a dabbling. Individual situations are very unique. So kind of where you go from here, if you would like more information, if you'd like to dig in a little bit deeper on a particular aspect of the portal or a tool that you have questions about, we are happy to schedule a demonstration just for you individually or for a group in your organization to see how that might work a little bit more detailed. If your organization already has access, so you technically could have access, but you've never tried to use it before, we're also happy to help just kind of walk you through a little bit of making sure you know how to get signed on, how to make sure you have access to the portal and all of that if your organization is already signed on. If your organization hasn't signed on and you think it sounds interesting, but you're not sure how to help that conversation through your leadership in your organization, we are also happy to help kind of talk through that and what that might look like and what might need to happen to do that. So basically all that to say, whatever we can do to work with you individually or your organization on next steps, happy to do that. Our general email here at info@healtheconnectak.org, you're certainly welcome to use that, but you're also welcome to reach out to any of us individually and we'll connect you with a resource to get you set up for your next steps. And with that, I think we will wrap up. We're right at 12:45, but I want to again thank you all for your time, for spending a bit of time with us, walking through this, and let us know how we can help and support you. And we'll hang out for just a little bit longer here if anybody does have individual questions that they want to stay on for. But otherwise, thanks for your time today, and let us know how we can support and work together with you. Have a good day.